I'm Dr. Sri Banerjee, core faculty for the College of Health Sciences and Public Policy at Walden University. And in this video, I'm going to go over the role of multimorbidities in chronic disease. So for starters, I'm going to share with you my perspective, where I got some of my experiences from, and by my idea is by sharing with you some of my experiences in research, I can then provide you with some guidelines on how to apply the principles of multi-morbidities to better understand how to study chronic diseases. So I'm gonna start just talking about when I was working in the family medicine clinics in Atlanta and seeing patients. Many times the charts, and back then we didn't have electronic charts, so the physical charts would have a whole list of various conditions. So when you're thinking, for instance, a person that has a chronic condition like heart failure, a lot of times the medications are working counter to each other, and this causes additional diseases and additional frustration on the part of the patient. What do I mean by that? Well, let me give you an example. So for instance, a patient comes in, they're maybe 63 years old, female that has had congestive heart failure for the last 5 years. And they come in complaining that during sleep they're having difficulties breathing. So many times you'll hear in the patient history that they're saying that they're having to lay on multiple pillows to be able to breathe, because a lot of the fluid, what happens during congestive heart failure, just quick physiology application, is that the blood flow starts to back up, because the heart is no longer pumping sufficiently. So the ejection fraction, which is normally 60%, is a lot lower. The impact, the effect, the outcome, for lack of a better term, on the individual level of that is that the demand for nutrients, for blood, for everything on the organic level, on organs, is not being met by the supply of the blood. So let's take, for instance, the liver. The liver is not getting the amount of nutrition and oxygenation that it needs when it's normally pumping. What does that cause? It can cause fluid overload. It can cause something called ascites from the liver, and so that causes a lot more backup, and then a lot of times conditions that mimic and that honestly are manifesting in right-sided heart failure. So I've just listed from left-sided heart failure, which is less than 60% ejection fraction, and shown you kind of in a logical manner where that leads to liver conditions like potentially ascites, and then other types of heart conditions. But then, of course, multimorbidities go beyond that, because then you have to be thinking about your renal system. The kidneys start to falter and be affected. It's called something called cardiorenal syndrome, and that was the topic of my dissertation. So kind of following along where I got my start, seeing patients, of course, in New York, Baltimore, Atlanta, but also taking that and then looking at many of those findings and trying to bring it together into one sort of cardiorenal syndrome, which is looking at it from a broad perspective. So what are some of the principles when you're looking at multimorbidities? So let's talk about now how you can apply what I call a multi-morbidities approach to understand chronic disease. Look, chronic disease is a very complex sort of condition. There's a web of causes and modifiers and combinations that lead to outcomes. But recognizing which parts come together and fit in understanding to produce the outcome, that is a challenge. So, for example, a cardiorenal syndrome, seeing that the heart and the kidneys are working together to produce that disease process, that recognition is important. So the combined cumulative effects lead to poorer outcomes than if they were to work individually. So, for instance, heart failure and chronic kidney disease are more harmful to the body than if they were to damage the body individually. Then what would follow is the idea that when possible, when there is a combination and an opportunity to study this by a sort of combination framework, please use that approach. So I'm gonna give you an example of this as well, and I think this will illustrate what I'm trying to say here. So say you have cholesterol readings for each individual because, for instance, we're using a robust surveillance system, National Health and Nutrition Examination Survey. So we have measures for cholesterol, but then we have, looking deeper into the data, there's actually information on 4 important variables, you find out later, that comprise metabolic syndrome. So you're trying to study the development of subsequent metabolic syndrome from pre-diabetes. Say you're trying to do that, and maybe you're trying to find how long it takes. Maybe you're trying to find just how many of the pre-diabetes end up turning into full-blown metabolic syndrome. So metabolic syndrome, of course, is not just hypercholesterolemia, as you know. There's also multiple measures, which includes abdominal girth. So these are all ways that are combined ways that comorbidities, multimorbidities can be used together to think in such ways. So I've shown you a couple things here. Started off by talking about multimorbidities and thinking about why multimorbidities are so important to not only consider, but why they have such an impact. And the idea is that individually, diseases don't have as much an impact as when they're working in combination. And then the other part of this really, and something I haven't mentioned yet, is the idea of side effects. And multiple conditions means the person is having to take a laundry list of medications, a lot of medications. So then they're having to count the symptoms and the side effects, and then consider that the new symptoms that they may be experiencing after adding on a medication may be from a side effect and not actually from a deteriorating condition. But you as a physician or you as a public health practitioner, healthcare provider, how do you make that determination? Is that new additional symptom coming from the diagnosis of the condition, or is it an additional side effect that was not considered? Again, seems on the surface a clinic question, something that should be only in healthcare, but believe me when I say this, these types of considerations only when you think of these do you have the whole picture of understanding the public health problem of, say, a condition like heart failure, or cardiovascular disease, or mental health. Um, so I hope this makes sense, some of these basic principles, and you actually use this in your research and in your daily public health practice. So in this segment of the video, I'm going to share an important multi-morbidity related article. And the reason I selected this article is uh, due to the title. It's an interesting title. The article is a bit dated as of this recording, but it's an interesting idea of multi-morbidity. What do we know, and what should we do? And it's a quality article in the Journal of Comorbidity, and looking at the idea that it's the co-occurrence of two or more conditions. That's what comorbidity, or that's what multi-morbidities are. And so this has really become over the last couple of years a priority agenda for policymakers. So patients with multimorbidities, of course, I talked about the problem of polypharmacy, but the other thing is a lot of times, because they're difficult to treat patients, they're high utilizers of healthcare resources. So for instance, if somebody is having trouble diagnosing multiple sclerosis and they're having to go through the workup of going through an MRI, 1.7 Tesla MRI, and they're not seeing any lesions and yet they're experiencing symptoms, then that will cause additional visits to the emergency department, and which is why it's important to get the diagnoses early on. But when you have complex conditions, like for instance the one I listed, MS, where it affects not one organ but multiple organs, then this can be a problem. And so it requires a different perspective. Multimorbidity perspective is different than just looking at one reductionist disease condition at a time, and then throwing a medication at it, hoping that it disappears. This, on the other hand, is looking at the conditions in the context of one another. So, just, in the introduction, talks about the urgency, especially felt by the European Commission and by the European Union. And so understanding the epidemiology, risk factors, and consequences of multimorbidity, that's really interesting. But the idea is that risk factors for multimorbidities, they haven't been well characterized. It's not exclusively by the elderly. Many studies report high rates of multimorbidity, even among working age adults. So definitely this notion it's a stereotype that it's only among the elderly. What are some conditions? I went over one. MS is more of a pro-inflammatory state. Sometimes a constant low-grade pro-inflammatory state will result in multi-system loss of reserve and function. So not only pro-inflammatory states, but multiple hormonal dysregulation. Thing with hormones is that the levels are not constantly monitored, and so what happens is there's fluctuations, and if there's parasympathetic, there might be sympathetic overdrive, or vice versa, and also increased susceptibility to other chronic diseases. So we saw this especially in COVID, because most people that the infection affected were the vulnerable populations, historically marginalized populations. And so when you have already this condition, this makes you more susceptible to diabetes and other chronic diseases, which we saw firsthand from research that was conducted, research that data that we collected, we found to be true. So women and those with a lower socioeconomic status also especially appear prone to developing multimorbidities. Um, this goes into a lot of different parts of the study. At least 50 million people in the European Union have multimorbidities. Um, and this number is only going to rise. Um, so the rest of this article looks at some model practices that can really target multimorbidities. Which priorities for a European policy are for multimorbidity? And so there's various ways that this can be addressed. How cost effective is integrated care for chronic conditions? How much do we know? Well, in the announcement for the Agenda for Sustainable Development 2030, of course, there's a discussion on universal health care. And so the shifting agenda away from disease-specific to integrated, systems-based approach, health for all, it's good. But the integration of services seems logical. That seems logical for high capacity health systems. So the idea is that the integration of services can be maintained. It sounds logical, but in a global community, cost effectiveness of integrated care approaches may not be the way. So emerging evidence from control studies reveal that transitioning from a disease-focused model to one of collaborative care delivery was indeed cost-effective and helped to eliminate cost redundancies when managing patients with multiple chronic conditions. So I think this is a good place to kind of start a debate here. So on one hand, it's really important to have disease-specific measures, because the idea is the more specific and the more targeted the therapy is, the more targeted the intervention is, the more effective it is. But then there's a continuum, and everything has a cost. For everything, there's a caveat. So the caveat here is that we're actually getting away from cost effectiveness, and in areas which are resource poor and already struggling for finances, it might be beneficial to have a more balanced approach of kind of a systems-based health for all and disease-specific, so that people can get the best care that they can from the healthcare system. So there were several interventions that were addressed and assessed to understand the different types of care and the effectiveness of the different types. While high-income countries are working to redefine how existing healthcare systems can address multimorbidity most efficiently, low and middle-income countries are facing additional challenges. For these countries, the battle to combat infectious diseases is ongoing against a backdrop of weak health systems and vertically focused donor approaches. So not only is there no alignment between what is needed and what is there, but also misalignment between what is needed and what is being produced by high-income countries. So what is the expectation is to promote these um, kind of vertically focused donor approaches, while that's not what is needed. So in South Africa, the prevalence of HIV is close to 30%. So this causes premature aging and the increased risk of cardiovascular diseases. And so again, the connections are again and again and again. What's being said is that this is a good tie-in to many different facets of public health, sustainable development goals, and understanding how multimorbidities have an effect in various geographic regions, not only in low middle income countries, but how that care is different in high income countries, and key prioritization areas. Um, I hope different facets of this and the illustration from the perspective of chronic diseases and infectious diseases has helped it better illustrate the idea of multimorbidities. Thank you for listening.